Now, today we'll be talking about the medicine diltiazem. So, diltiazem is very important and interesting medicines, and it is very commonly used in ICU settings, especially in emergencies. So, it is class 4 antiarrhythmic drug. It is a calcium channel blocker. So, basically, what it does is it depresses or it inhibits this calcium mediated depolarization. So what it does is it simply suppresses the automaticity, and this automaticity is the major problem for arrhythmias, especially SVT, atrial fibrillation. So it also inhibits the re-entry. So it inhibits or depresses the depolarization, suppresses automaticity, also suppresses the re-entry. That is the reason why in atrioventricular or re-entry tachycardia, AVRT, diltiazem can be extremely effective. The most important effect of this diltiazem is prolongation of AV nodal refractory pathway or potential. That is how the AV conduction is markedly slowed and the PR interval increases, and then it markedly improves the tachycardia, or it simply abolishes the SVTs and atrial fibrillation. So this is the AV nodal refractory. This is the AV node where it actually acts, it slows down the AV conduction so that the PR interval increases and the extremely high rhythms which are getting originated in atria are not transmitted to the ventricles, and then SVT or AVNRT or AVRT, it is then abolished. So re-entry is also terminated, which is actually the basis for involvement of this re-entry is AV node, and diltiazem has a very good activity at AV node. That is the reason why it can abolish the SVTs, the atrial fibrillation, as well as the re-entry as well. And this diltiazem doesn't at all affect the intraventricular conduction, which is a plus point for this diltiazem. So where it is used, most of the time it is used for supraventricular tachycardia, that is paroxysmal supraventricular tachycardia. It is very extremely easy to administer, is very effective. The efficacy is around 80%. So out of 100, around 80 will definitely revert. We can definitely use adenosine for that as well. But when adenosine fails, because whenever we give adenosine 6 milligram followed by 12 milligram followed by 12 milligram, even after this giving adenosine, if it is not reverted back to the normal sinus rhythm, dilsem can be 5 to 15 milligram or 20 milligram can be taken. One vial usually contains around 25 milligram of dilsem. So this 25 milligram can be diluted in NS in around total 10 ml NS, and 5 to 15 milligram can be slowly given over a period of 2 to 3 minutes, and it improves or it terminates the SVT in front of your eyes on monitor. So once this SVT is terminated, once that it is terminated into normal sinus rhythm, then we can start this patient on oral dosage of diltiazem, and that is usually 60 milligram per oral immediate release diltiazem that is given every 8 hourly, thrice a day. Once the blood pressure is controlled, once the heart rate is settled, once as soon as the heart rate is settled, once the heart rate is around 60 to 90, the sinus rhythm or very well controlled rhythm, then this 60 milligram 3 times a day can be converted into 90 milligram sustained release every 12 hourly, and that the medicine is then continued to prevent the recurrent paroxysmal supraventricular tachycardia over a period of months to years. The second most effective application of this diltiazem is atrial fibrillation, especially for new onset of atrial fibrillation. Cardiron is extremely effective in this atrial fibrillation. Amiodarone, 150 to 300 milligram is extremely effective for atrial fibrillation. Beta blockers are effective, but apart from that, diltiazem is one of the most effective medicine against this atrial fibrillation. Now, whenever suppose cardaron doesn't help to revert the atrial fibrillation to normal sinus rhythm, or if the heart rate is high, that time diltiazem can be 100% tried. The dose is again remains the same. 5 to 20 milligrams of diltiazem can be taken, and it can be given over a period of 2 to 3 minutes slowly while monitoring. And once the heart rate is controlled, or once the heart rate is in between 60 to 90 or 60 to 200, Once the heart rate is either sinus or even if it is AFib but controlled, the patient can be shifted to 60 milligram per orally every 8 hourly. And once the heart rate is very well controlled, then the patient can be shifted to 90 milligram sustained release every 12 hourly. Apart from that, the third indication is reentrant supraventricular tachycardia and nodal arrhythmias, because we know that it acts very well on AV node. But it is totally contraindicated in patients with wide or broad QRS complexes, Wolff-Parkinson-White syndrome, that is WPW syndrome. Also, in VT, it can actually precipitate ventricular fibrillation and patient can die also. That is the reason why it is not at all recommended for routine use in ventricular tachycardia, where we have cardaron as a potential drug of choice. When compared with verapamil, the diltiazem has very lesser chance of hypotension and myocardial dysfunction. So this drug can also be used even in presence of mild to moderate congestive heart failure when the patient has atrial fibrillation or paroxysmal tachycardia, uh, supraventricular tachycardia or reentrant SVT or nodal arrhythmias. So that's all for today. Thank you.